Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi taala wabarakatuh. And very good morning. Let's start our session for the first symposium. Okay, it's a very bright Saturday. The first symposium will be on regional anesthesia. I would like to first introduce Dr. Sze Teck. Okay, Dr. Sze Teck is the fellow of regional anesthesia subspecialty program. Okay, so I'm proud that we have produced specialists in regional anesthesia in the country. Okay, so Dr. Sze Teck graduated in 2006 from University Science Malaysia, and he got his master's in 2015, and I think he joined later in the regional anesthesia subspecialty training program. So he had, become trainer, facilitator, speaker in various workshops in the country. So I don't have to elaborate on that. So the first talk will be on the current analgesic technique for PKR. So before we proceed with the talk, I would just remind the speaker that they are allocated about 40 minutes for their presentation, and following both presentations, there will be, at the end of both presentations, there will be a 10-minute question and answer. And in the last 10 minutes, a play card will signal the remaining time. And in the final 2 minutes, a bell will ring to signify the conclusion of the session. After 10 minutes, if there are any extra questions, they will be addressed through the virtual platform. So without further ado, I invite Dr. Sze Teck for his talk.
Okay, thank you, Dr. Amir, for the kind introduction. And good morning and greetings to all. Thank you to the organizing committee for inviting me to share my view and on this topic. So without further ado, I'll just proceed with my talk. So the topic given to me will be the analgesia for total knee replacement. What are the current evidence? What are the things? Perhaps what we usually practice, well, maybe change, maybe a different from what is practiced around the world. Yep. So first of all, I have no disclosure. I have no conflict of interest. I want to show this slide. So, sadly, Malaysian is an aging population. The number of the people more than 65 years old is rising. In 2020, it's about 7.2%, and it's projected to rise further. Further and further. And as life expectancy increases, the problems associated with aging increase. One of the problems associated with aging population is aging diseases, diseases like osteoarthritis. So the global trend of osteoarthritis has increased so much. And out of all the sites of osteoarthritis, the knee joint is the one most affected. So you can imagine that so many people having OA of the knee, and after after they have exhausted all their therapies, physiotherapy, medication, in the end, they have no choice but to undergo a surgery, undergo knee replacement. So look at from this slide, I just want to show that the peak age of osteoarthritis, especially osteoarthritis of knee, starts at 50 plus years old and until 70. So yeah, you can imagine if our population, we have more and more population in that age bracket, then we have more and more, chances are there will be more and more patients presenting with osteoarthritis, and there will be more and more patients requiring total knee replacement. And those patients will come to us, and we have to treat them. We have to give them anesthesia, provide them, try to facilitate the process of surgery and recovery, and hopefully recovery, and yeah. So yeah, total knee replacement is getting more and more. Yeah, there's estimated about 40,000 cases, primary total knee replacement in US. And the aim of total knee replacement is actually to, relieve pain. One of it is to relieve pain, restore function, and improve quality of life. Unfortunately, total knee replacement is associated with moderate to severe post-operative pain. So much so that some patients actually refuse operation just because in anticipation of the post-operative pain. Yeah. So ironically, treatment modality that is supposed to reduce pain, restore function, actually cause a lot of pain. Yeah, during that rehabilitation process. So why TKR is so painful? Why? So you know that the knee joint is a complex joint that has multiple innervations. And during the surgery, there will be these incisions through all these structures like the skin, subcutaneous tissue, not forgetting the arthrotomy, and then the fibrous cap. So the pain will come from the fibrous capsule, cruciate ligaments, muscles. So yeah, and not forget that after surgery, there will be inflammation, and the pain is actually sometimes quite severe, and yeah. But total knee replacement has how to call evolutionized and revolutionized. A lot of techniques introduced, like more precise planning by the surgeon, mainly more precise planning, good imaging and 3D modeling of the knee joint of the patient, facilitate the planning of the surgery, which result in less, so they can cut more precisely, and there will be less tissue trauma, less pain, and hopefully a little more recovery. And then there's the introduction of this navigation system and robot-assisted system. All of this will hopefully make total knee replacement less painful, less traumatic, and hopefully promotes a faster recovery. But is that true? How true is that? Well, in actual fact, in order for the surgery to be a success, actually, the surgery itself is just a small part. Look at this. This is in this diagram, I'm just trying to illustrate that in order for a patient to successfully rehabilitate, undergo a successful total knee replacement, it's not just about the surgeon or the surgery technique. It's about managing the patient from pre-operatively, proper counseling, start rehabilitation, and then proper counseling, and then intraoperatively, the use of analgesia from pre-op, intra-op, and post-operatively. Yeah. So all this will affect the rehabilitation. So it's actually, we need to properly plan. And as the number of total knee replacement is anticipated to increase, the workload is anticipated to increase. We cannot have patients staying in the ward for 1 week post-operatively. We need to faster the recovery. So that's why we need a proper planning. We need to sit down, talk to the surgeon, plan, select the patients all those primary TKRs that are suitable to be enrolled in an enhanced recovery program. Yeah. So the basic of pain management in total knee replacement. So we cannot run away from these three principles. Now, especially, I think moving towards the future, these are the main principle. We need to have multimodal analgesia, which is proven to be effective. We need opioid-sparing anesthesia and analgesia to reduce the side effect from opioids. And now one more thing is we need to provide analgesia that allow early mobilization, and this is the challenge. How can we, at the same time, provide good analgesia, but also allow patient to mobilize? So the bulk of my presentation will revolve around this paper. This is a prospect group. This is a group of surgeons and anesthetists who come together and review all the relevant meta-analysis and RCTs, and to come out with a recommendation. Yeah, this group actually, they come out with recommendation for a lot of other procedures, thoracic surgery, abdominal surgery, and TKR is one of them. So yeah, we'll review the evidence here. All right. Yeah, basic analgesia, paracetamol and non-steroidals. Yeah, these are very basic analgesia. So a lot of studies have been done on this, and it shows that they have some opioid-sparing effect, but they have to be used in a multimodal analgesia setting. It cannot be used as alone, as sole analgesia. But when combined with other modalities like blocks, like local infiltrations, and the added benefit of paracetamol. So paracetamol has very minimal side effects. So you have something that can provide opioid-sparing effect, and at the same time has minimal side effect. So it is highly recommended to be given. So, but the timing to be given, well, actually, it's recommended that you start the patient pre-operatively, even though the evidence is not that strong. Preemptive analgesia, well, we know it's not really proven. But the more important thing, rather than preemptively before incision give the analgesia, is actually provide good duration of analgesia throughout the operation. So, well, the recommendation is to start paracetamol pre-operatively, then intraoperatively, and continue post-operatively. How about NSAIDs? NSAIDs, we have the non-selective and selective COX-2 inhibitors. So they also provide opioid-sparing effect, but need to be a part of a multimodal analgesia setting, not as a sole analgesia technique, especially for TKRs. Yeah. Timing also the same, pre-operatively, intraoperatively, and post-operatively. So a couple of meta-analysis because I think most of us, when we want to use NSAIDs, we are concerned about certain things. Of course, if the patient has renal failure, no, not out of question, no. Patient has ischemic heart disease, will be a bit concerned with using COX-2. Then the other thing is bleeding. So, however, especially for TKRs, we are concerned because of bleeding. Sometimes we don't want to use COX-2 inhibitors like paradoxics. But a few meta-analyses have shown that there's no major adverse effect. So other adjuncts, well, can we use other adjuncts like ketamine, Presidex, gabapentin? Well, and so so far there is lack of evidence for these. Like dexamethasone, we are not sure what dose to give. When the prospect group they reviewed, they found that there's a wide variety of dose of dexamethasone used from 10 milligram until 25 milligram. That's very high. Yeah, actually we commonly give dexamethasone as an antiemetic. So we can continue with that, and then it will have some effect, like prolonging regional anesthesia and also provide some analgesia effect. So yeah, but not high dose, not high dose. We use the common dose that we use for antiemetic. Yeah. Then gabapentin, yeah, I know surgeons like to give gabapentin. Yeah, they like to start patient routinely start patient preoperatively on gabapentin, but it's shown to have no. Then the dose is no standard dose, and then not to forget that gabapentin, all this, and pregabalin all have sedative effect, and the majority of the patients are elderly with mobility issue. Some have mobility issue because of the OA, knee OA. So yeah, we have to be careful. Ketamine, not much of the evidence as well. And Presidex, dexmedetomidine, no evidence also. So not recommended. Wow. Next, the prospect group look into intrathecal morphine. Yeah, since we are most of the time, if our total knee replacement is done under spinal anesthesia, yeah, maybe we could add opioid like morphine, a long-acting opioid, morphine, to minimize opioid use post-operatively. Yeah. So yeah, it has been the prospect group have looked into this intrathecal morphine as a modality to reduce opioid and also to improve pain post-operatively, and they found that compared with the femoral nerve block, it actually has a similar efficacy. However, intrathecal morphine has its problems. It's not without problems. Common problems like nausea, vomiting, pruritus is very, very common. Yeah, even the dose of 100 mics. And not to forget, even though it was not reported, not found by this prospect group, there is this problem of delayed respiratory depression. Yeah, even with, and mind you, the patients undergoing total knee replacement are most of the time elderly patient, and that would make us think twice about using intrathecal morphine because of that respiratory depression, even though the prospect group did not report any incident when they look through the evidence. But so yeah, now coming to my favorite part, regional anesthesia for TKR. Regional anesthesia, yeah, actually regional anesthesia is a very good modality for TKR. So before we look into the blocks that we can use or the regional technique that we can use for TKR, let's look back at the innervation of the knee joint. So the knee joint can be divided into an anterior part and posterior part. Anterior part, well, mainly the innervation is by the saphenous and common peroneal, and also branches from the femoral nerve. While the posterior part is innervated by a branch of the tibial nerve and obturator nerve. So yeah, this author actually suggested that in his paper in 2017, actually suggested multiple nerve blocks, mainly femoral nerve block and sciatic nerve block, combined of a femoral and sciatic nerve block. He suggests that this would be a very good block to be done for total knee replacement. However, if you look at the surgical approach for TKR, the usual approach would be a medial parapatella or mid-vastus or subvastus approaches. So from this, the tissue trauma, the injury, the inflammation mainly is around the medial area, medial side of the knee. So the important nerve that you should block actually are the saphenous, nerve du vastus medialis, and medial femoral cutaneous nerve. So in that sense, actually blocking femoral nerve alone is actually good enough to cover majority of the pain from TKR. Yeah. And let's look a bit on the femoral nerve and its branches. Well, the femoral nerve actually enters the femoral triangle and branches out very early. And when it branches out into the saphenous and also all the motor nerves to the vastus muscle, vastus intermedius, medialis, lateralis. So Inside the femoral triangle, you have all the branches, the motor branches for the quadricep muscle. You have the saphenous, you have the medial femorocutaneous nerve. Then at the apex of the femoral triangle, which is when the sartorius intersect with the adductor longus, that marks the end of the femoral triangle, which is also the beginning of the adductor canal. So inside the adductor canal, a lot of authors have written that the nerve that inside is mainly the saphenous nerve, medial retinacular nerve, and also posterior branch of the obturator nerve. Some authors, some cadaveric study has shown that the nerve to vastus medialis can be in the canal, some said outside the canal. So what does this tell us? That if you place your block more proximal, you block more. If you block the femoral nerve at its at the inguinal area, you block the femoral nerve totally, you block everything. But if you do a facial plane block in a femoral triangle, you may cause less motor blockade and good analgesia as well, may achieve a similar efficacy of analgesia compared to femoral nerve block. And if you move down some more into the adductor canal, you can achieve a motor sparing analgesia. Okay, that's the what I'm trying to say here. So adductor canal has a lot of controversies. Yeah, the definition. I think in the prospect group, all their studies on adductor canal, well, how they define the adductor canal mainly is where this landmark technique. They take a midpoint between the ASIS and the patella, and then they mark it, and they say that is the apex of the femoral triangle, which is the beginning of the adductor canal, which is the adductor canal. So nowadays we can use ultrasound to help us to find the apex of the femoral triangle. Using ultrasound, we can actually pinpoint where the sartorius intersect with the adductor longus, and we mark that as the tip of the femoral triangle. And then we identify below that will be the adductor canal. Below that until when the superficial femoral artery separates from the sartorius, that marks when the superficial femoral artery separates from the sartorius, that's the end of the adductor canal. So that when we can actually pinpoint the adductor canal and give a block inside. But very few literature has compared where you inject the where if you inject in the femoral triangle or you inject in the adductor canal, any difference. So very few studies have studied the difference between injection at different sites. But what we know for now is that if you go more proximal, more motor block, probably more analgesia effect, because you block more nerves, logically. And if you go more distal, you might block less nerve, because at one point of time, the saphenous nerve also leave the canal if you go too distally. So yeah, you might cause less efficacy in the analgesia, but you have motor sparing effect. So the prospect group not just look into peripheral nerve block, it also look into epidural actually. So we start off with the epidural analgesia. So the prospect group look into the epidural cocktail, which contains LA, fentanyl, and then a lot of other adjuncts. So the study that involves epidural for TKR has, it's quite varied. They use a lot of drugs, and compared with the femoral plus sciatic nerve block, actually the epidural has no significant difference in pain score for the first 48 hours. So, but it carries a higher risk of nausea, vomiting, hypotension, and urinary retention. Quite logical because of the adjunct they use. So, yeah, some of them even use clonidine. So, but we don't use here. So, and compare with local infiltrative analgesia, which I'll talk about later. So, there's also not much difference in efficacy and opioid consumption. So in the end, because of the side effect of this side effect of urinary retention, hypotension, nausea, vomiting, prospect group actually don't really recommend the epidural for this total knee replacement. Yeah. How about femoral nerve block? Well, yeah, just now I mentioned that femoral nerve block is actually a very effective nerve block to be done for total knee replacement. It's easy now with the ultrasound guided technique. It is quite easy. It can be easily achieved. So, and it's effectively block all the nerve that supply the anterior, most of the anterior knee joint, which the pain comes from, from TKR. The prospect, all this about the prospect's findings. They studied the papers that compare femoral nerve block and adductor canal and also local infiltrative analgesia. They found that it has similar efficacy. Wow. Well, however, femoral nerve block has that disadvantage of having the quadricep weakness. And sometimes if your surgeon wants the patient to move early, as early as day one, so it is very difficult. It will be very difficult for the patient to move with motor blockade. So yeah, so actually prospect do not recommend femoral nerve block. Yeah, I know this might be a bit hard to accept, because we all think that the femoral nerve block is actually the most effective block for TKR, but actually, but I think the prospect group take into account the need for early mobilization for TKR. That's why they don't suggest the femoral nerve block. How about additional exciting nerve block? Well, yeah, actually, no, they don't recommend also because it did not improve. Additional exciting nerve block did not improve analgesic efficacy, and also it produced motor blockade. It will cause foot drop. So yeah, no. Yeah, so actually prospect actually highly recommend the adductor canal block because, but not as a sole block. So if you want to perform, if you want to give your patient an adductor canal block, I think you need to have some mental preparation. It doesn't behave like a femoral nerve block. It will not behave like a femoral nerve block. Yeah, you won't get a very dense blockade. Yeah, because you want a motor sparing effect. So the downside of it, your analgesic efficacy might be less compared to a femoral nerve block. Even though the study from the prospect that they looked through, they said no difference. But in actual fact, yeah, there is a difference. That's why they recommend that the adductor canal block be given in a multimodal analgesic setting. What do you mean by multimodal analgesic setting? You give your patient PCM, NSAIDs, and you be prepared. They will need opioids. They will need. Yeah, it's opioid sparing. It's not that if you give this block, then they will not need any opioids. No, they will need. Okay, probably just less. Yeah. Okay. So yeah. So compared to ACB with femoral nerve, single shot or continuous, doesn't matter you put catheter, doesn't matter that or you compare single shot. There's not much difference in analgesic and opioid sparing effect. That's the finding from prospect. So yeah, because of that quadricep sparing, the motor sparing effect of adductor canal. So that's why prospect recommended this adductor canal over femoral nerve block for total knee replacement. So how about single shot adductor canal versus continuous adductor canal? We know that adductor canal is not a nerve block. When you inject LA inside the adductor canal, you're not looking for the nerve. Unlike femoral nerve block, you actually look for the nerve. You actually inject. They try to place the LA as near to the nerve as possible, probably in the nerve sheath. But in the adductor canal, it's considered as a facial plane block. Facial plane block means you inject in the muscle plane. The adductor canal is a myofascial plane. You inject in the plane, hopefully the LA will be carried to the nerve by the muscle. So you use higher volumes. But the adductor canal, usually we don't use that high volume because it's a very small compartment. So your usual single shot dose is 20 mils, but we use diluted LA. So that's why some people say that because it's a facial plane block, some people argue that it's a facial plane block, it wears out very fast, we should put a catheter. So the prospect group look into a few RCTs. I think here about 7 that shows that there's not much difference whether you put a single shot or you put a catheter. So yeah, but I think this one will about this single shot versus catheter. There will be more studies coming out as we go along. As more and more adductor canals are being done, some people would like to put catheters, and then there will be more evidence out. I think in this area there will be more evidence. So yeah, like this one, this review article that I found that actually shows that actually the continuous adductor canal block is actually more effective in managing pain in the first 24 hours compared to the single shot, right? So, but if you ask me whether you want to use catheter or you want to use single shot adductor canal, you need to take into account a few considerations. Yeah, you use catheter because you want to prolong the duration of the analgesia, and you want to reduce the likelihood of using a rescue opioid because you can use rescue LA. But the problem with catheter, one thing is infection. Number 2 is cost effectiveness. If your patient is anticipated to recover within 2 or 3 days, would you use a catheter? And yeah, on the background, multimodal analgesia, you got other modalities. Would you use a catheter? Yeah. So next, I think, yeah, this one is the local infiltrative analgesia. Well, this one, actually, Prospect actually recommend local infiltrative analgesia. This is not our field, not the field of anesthetists. This is the field of the surgeons. So infiltrating LA, there are a lot of variation. Some put it intraarticularly, some inject in the compartments. So what I found that the first periarticular injection was introduced by this Kerr and Cohen in 2008. So they actually use very high dose ropivacaine, 400 milligram maximum. They use 300 milligrams. So they give separate injections, injection into the various compartments, okay, at different timings, and they target the posterior capsules and the lateral collateral ligaments. So in the setting of multimodal analgesia with celecoxibs and total knee replacement, the pain scores are actually quite low. And then the length of hospital stay is actually very low. And the effect actually lasts, look at the pain score, the lower one. Actually, the pain score, actually, it can last until 48 hours. Yeah. So, but there are a lot of variation in this periarticular injection. So when you look at 3 authors, all 3 different doses, bupivacaine, ketorolac, and some ketorolac, some don't use, some use adrenaline, some don't use adrenaline. And you look at the things that they put into their periarticular injections. So there's a lot of variation, what I'm trying to say. So, and not all surgeons are comfortable doing it. And some surgeons will put catheter. The first author actually put catheter, but because of risk of infection, I think a lot of surgeons will not use catheter. So Prospect actually recommend local infiltrative analgesia combined in a multimodal setting. And then they actually also recommend combining your adductor canal block with the local infiltrative analgesia. So based on a few RCTs, again, they recommend that actually it improves the compared to either you use an adductor canal block alone or a local infiltrative analgesia alone. If you combine the two, you have increased efficacy. But remember, they are using a lot of very high dose, so the concern will be local anesthetic toxicity. So far, not much. There's no reported major adverse event even when combining LIA and SCB. So this is one of the trials that very few patients, because this is very hard to do. They have to give the block and then measure the plasma concentration of ropivacaine. So actually the plasma concentration of ropivacaine peaked within the first hour after LIA, after local infiltrative analgesia. But the free portion of ropivacaine always remains lower below that. dose that can cause LAS. So luckily, so this is another article that studied high dose blood samples of concentration of ropivacaine after periarticular injection. So they found that even though it peaks, but then, yeah, it does never reach that toxic dose. And no adverse event. The most important thing is there's no adverse event. So overall, final recommendation by prospect. Well, yeah, I think, but this is just a guideline. Again, it's a guideline. It's a guideline. It's meant to be as a guideline. You can just take it and you see whether it's suitable for your local setting or not. Okay. I think the aim is actually to balance the analgesia and the early mobility. Yeah, you don't want to have a patient who has no pain but cannot walk. So yeah, so they recommend, yes, paracetamol and NSAIDs as a baseline, then combined with the local infiltration and adductor canal block. And on top of that, you will still need your opioid rescue. So yeah. Okay, these are the drugs that are not recommended. Okay, so the limitations, they only review the studies that only include primary TKR, not redo, not the complicated ones, not the patient with the chronic pain. So these population you have to look into, have to treat differently, a bit differently. Okay. Yeah, and continue advancement. So this prospect was published in 2022. Since then, other new evidence might have come out. Evidence such as this, another meta-analysis that compare 5 motor sparing technique. Yeah, LIA alone, LIA plus single shot SCB, and then LIA plus single shot SCB plus IPAC. So yeah, all this we are continuing doing. For your information, IPAC is the injection at the done by us, anesthetists under ultrasound. Is a type of block that we inject between the posterior capsule, the knee joint, and the artery. We are actually, I think, in my opinion, the IPAC targets the same posterior capsule as the LIA does. So probably it doesn't, if you are giving, the surgeons are giving LIA, maybe no need. Yeah. So here are my references, and thank you.
Thank you, Dr. Sze Teck, for the comprehensive review of the current analgesia for PKR surgery. I think Dr. Sze Teck just said that you have committed a big sin if you still use epidural analgesia. So, okay, so next speaker.